Hey everybody, welcome back to my YouTube channel. Today we're going to be talking about Patulous Eustachian tube, which is one of my most favorite things to talk about and to see in the clinic. So Patulous Eustachian tube is when the Eustachian tube stays open. So again, the Eustachian tube is a valve that connects the back of the nose and throat to the middle part of the ear. It helps keep air in the middle part of the ear. That's why when you yawn or swallow, air equalizes through there. And ideally, the Eustachian tube opens intermittently, but then it closes back shut. So it's important for it to stay shut to protect the middle ear from sounds in the back of the throat and from secretions or food and drink when you're swallowing, things like that. So it needs to open, but it also needs to close. So in a patulous Eustachian tube, the Eustachian tube is not closing. So imagine it being kind of a leaky valve. And the symptoms that patients will experience with this are usually a clogged, stuffy ear, which is very similar to patients who have a blocked or obstructed Eustachian tube. So it can be very confusing because it can feel very similar. So it might feel like pressure or fullness or like there's cotton in the ear. But the kind of distinguishing feature is that they will hear echoing of their own breath and voice into the ear. So we call that autophony. And so they might, some patients will say they kind of feel it open up and then suddenly they're hearing their internal sounds louder than they hear the external sounds. So they will also frequently complain of muffled hearing because the internal sounds of their own breath are masking kind of what they're hearing from outside. And one of the key features is that many patients have figured out that when they lay down, they feel better. And so typically patients, after they've been laying down all night, when they wake up in the morning, they'll feel better, and then slowly it gets worse and worse throughout the day. And then the cycle kind of repeats itself. What causes it? So there is a high association with rapid weight loss. So for example, in patients who have had gastric bypass surgery, or now with the GLP-1 drugs, patients are losing a lot of weight fast. That can precipitate patulous Eustachian tube. And we're talking like, it can be 20 or 30 pounds, can be 50 or 60 pounds, but it's generally that kind of rapid weight loss. And the reason for that is that because within the lining, the internal lumen part of the Eustachian tube, there's an area where there's usually this little fat pad. And so when patients are losing weight really quickly, they lose volume within where that fat pad is. So they're losing fat inside the Eustachian tube. And so that makes it to where it can't close very well. There are anything else that causes a rapid weight loss. So for example, patients who were hospitalized with a severe illness and lost weight, or a new cancer diagnosis, or other health conditions like that where there's a rapid weight loss. There is an association with environmental allergies. And so it is very common for patients to tell me that they've had like allergies with runny nose and sneezing and that sort of thing for their entire lives. And a lot of those patients may have experienced a blocked Eustachian tube in the past, and now it's more of a problem with it being too open. There's a very high co-occurrence with stress and anxiety. So about a third of patients have a history of anxiety and may be on a medication for anxiety. Many patients will tell me that stress makes it worse, makes their symptoms worse. And then other common associations are reflux and autoimmune disorders, as well as neuromuscular disorders. But I think some patients can have a neuromuscular form of patulous Eustachian tube. And what I mean by that is that the muscles that pull the Eustachian tube open are getting stuck like that, such that the eustachian tube is being propped up open by those muscles, and it's not necessarily a problem with losing volume in that fat pad that we discussed earlier. Okay, so how do we diagnose it? So most of these patients will have a completely normal workup, meaning when you look at their ears, their eardrum looks normal. When you test their hearing, it looks normal. When you get tympanograms that measure how the eardrum moves, it looks normal. CT scan looks normal. And so a lot of times I'm seeing these patients as a third or fourth or fifth opinion. And that is usually the history, is that no one can really figure out what's going on. And so the diagnosis really relies on asking the right questions and having a very high suspicion for patulous, being on the lookout for it. I think now that there are so many educational materials available online, I have more and more patients who are coming to me and they are saying, I think I have this, because they have looked online. But the other challenging thing with patulous is that it can be hard to describe. It's a sensation that they have trouble putting words to. But most patients will describe it as like an echoing or a reverberation, or having like a speaker in their ear. All of those are very common descriptions of it. For my workup, so if you are seeing me in clinic, I'm going to look in your ears. And when I'm looking in your ears, if I see the eardrum moving with your breath, that is highly specific for patulous. So that is not normal. I don't usually see that unless a patient is patulous. And so when I see that, I'm like, aha, this is a patulous eustachian tube. However, patulous can be episodic. And so sometimes patients are not experiencing their symptoms when they're sitting in the office with me. And so I may not see it. So just because I'm not seeing the eardrum move with their breath doesn't mean that they don't have patulous, right? What else am I looking at? When I will always do a nasal endoscopy, meaning I use a small scope. I place it inside the nose. I go all the way to the back of the nasal cavity and look at the opening of the eustachian tube. And typically with a patulous eustachian tube, the eustachian tube looks wide open, like a cave or a funnel. You can see all the way down it, as opposed to usually it will look more like just like a little slit, because it is typically closed at rest. And so I'm looking at the eustachian tube itself. I'm looking at the eardrum to see if there's any particular movements. Obviously, I look at an audiogram, a hearing test, and what's called tympanograms, which measures how the eardrum moves. Those are all helpful as well. But a lot of times the diagnosis can be made in clinic without any additional testing. So if we do determine that we think this is patulous eustachian tube, what do we do? What's the treatment? What can be done for it? So I kind of approach this and explain it to patients in 3 buckets, okay? So the first bucket would be conservative treatment, conservative measures. And so the first one is usually removing all of the allergy and decongestant medications that patients have been placed on, because frequently patients have been misdiagnosed as having a blocked eustachian tube. And so they might be on like a steroid nasal spray, like Flonase or fluticasone, Nasonex, something like that, which theoretically can make patulous worse. So we remove that. They might be taking a decongestant like Sudafed. We remove that. I emphasize the importance of hydration, because we want those tissues of the eustachian tube to be hydrated so that they are plump enough to kind of come together and close well. I do ask patients to decrease caffeine if that is something that they are open to or willing to do. I know everyone loves their morning cup of coffee, which I do as well. And some patulous patients can have a little bit of caffeine and it's not a problem, but But caffeine is a diuretic and will tend to dehydrate the tissue of the eustachian tube. So any little thing you can do to help is worth talking about, right? There are some medications that can make patulous worse. So things like diuretics, spironolactone, stimulants. So I have a lot of patients who are on stimulants for ADHD. And so we talk about whether or not it's possible to come off of those medications. And sometimes the answer is no, and that's okay. But it's worth a discussion of whether that might be something to consider. And then we move, if we try all of those things and there's no improvement, then we move on to bucket number 2. And so the second bucket is topical drops to the eustachian tube itself. So what I mean by that, so these drops go through the nose and they trickle back and sit at the opening of the eustachian tube. And the goal of these drops is to irritate and inflame that mucosa so that it swells a little bit so that the valve can close, okay? So there are different agents that can be used. So hypertonic saline is usually my first go-to because it's really cheap and it works. I will put a link here for a video showing how to mix it. But typically, it is a lot saltier than what you would use for just a saline rinse or saline spray when you're cleaning your nose or moisturizing the nose. But super salty, and you're gonna just drip it down the nose. The hardest part of this is positioning and getting the drops to go where you want them to, because the eustachian tube is in a challenging place, and so frequently you're gonna have to lay back and tilt the head to whichever side that the drop is going down, such that it will make it to the eustachian tube opening. The other downside about it is that it tends to sting and burn, and so as it's trickling down through the nose to get to the eustachian tube opening, it can burn and sting on the way there, which is also just, it's uncomfortable. So it does get better over time the more you do it. And these topical drops are not meant to be forever options. A lot of times patients can use them for a few months and then they are better and then they stop. Hypertonic saline is effective, but then there are also vitamin C formulations that can also help. So I talk to patients about both of those and try to get them to stick with them as long as possible. And sometimes they can't. Sometimes they just can't get it to get to the opening of the eustachian tube. Sometimes it makes them gag or throw up. And so, you do the best you can. And if it doesn't work, it doesn't work. Okay. Moving on to bucket number 3. So when conservative measures have not worked, then we start talking about procedures. These procedures come in 2 main flavors. One would be procedures that approach from the ear, and the other would be with an approach through the nose. So things we can do from the side of the ear would be mass loading the eardrum, which usually just means placing a little bit of medicine or paper or silicone on the eardrum itself, which makes it a little bit heavier, with the idea being that it's not going to move so easily with your breath and voice if it is heavier. This is nice because it can be done in clinic. If it is effective, the permanent version would be to do what's called a cartilage graft tympanoplasty, which we bar a little cartilage from your ear here, and we permanently make your eardrum a little thicker and a little bit heavier. The other options, going through the nose, would be the procedure that I've had the most success with is called shim surgery. And with this, we create a shim, which is an angiocatheter filled with bone wax, and it is guided into the lumen of the eustachian tube with a goal to partially occlude or block the eustachian tube. Now, again, the goal is to make it such that it is closed enough that the symptoms are gone, but open enough such that air can equalize around the shim. In my experience, it is very common to occlude or block the eustachian tube so much that a tube is needed, meaning you put a little hole in the eardrum. And the combination of those together, for me, has had the best success. Other things that can be done from the nose side would be injecting filler into the lumen of the eustachian tube to kind of replace that volume that was lost. So especially for patients who had a patulous from a big volume loss, you inject filler to kind of replace that area where the fat has atrophied. The problem with that is that it tends to break down over time, so it doesn't last as long. And then lastly, there is a procedure where cartilage grafts are placed within the lumen of the eustachian tube, again, to fill that volume deficit. And so all of these are procedures that I discuss with patients to help get towards symptom resolution. And I think for me, the procedure that has had the most success and is the most predictable is placing the shim. I do counsel patients, though, that it is not a perfect surgery. And so because we are blocking off the lumen of the eustachian tube, we have to be prepared for the consequences that come with that, which usually can be fluid buildup in the ear, the requirement for a tube. Sometimes that tube will intermittently drain fluid. Sometimes that tube can cause a difference in hearing. And so managing expectations is really important because sometimes we're trading one problem for another. And so I think it's just important to keep that in mind. I do want to discuss another subset of treatments that I have observed being successful in certain patients. I mentioned that there may be a neuromuscular form of patulous in which it is the muscles that are hypertonic, or meaning they are overactive or in spasm where they're holding the eustachian tube open. In this patient population, because it is not a problem with a loss of volume, I have seen some success with neuromodulating medications because it is a neuromuscular problem. It is not a problem of the mucosa or the fat that's underneath the mucosa. And so for some patients, it may be worth considering a trial of medications. Like I've seen success with a medication called duloxetine. I have heard from patients who have been treated elsewhere that an SSRI may be helpful. And so this is another area that is a little maybe not well explored at this time. So more to come on this. But I do think if there is suspicion that this could be a neuromuscular problem, that it is worth seeing if treatment down that pathway could be helpful before doing any sort of procedures, especially. Sometimes if there is concern that there might be a temporomandibular disorder co-occurring, which is actually relatively common, where patients have either chronic clenching and grinding of their teeth or of their jaw, it's worth having that looked at, potentially starting physical therapy for that. I think that is also helpful for long-term outcomes. But overall, the main take-home points regarding patulous is that it can be a very challenging diagnosis. But I think for many patients, once they have a diagnosis and an understanding of what they are experiencing, and to know that they're not crazy, and just because all of their testing is negative, it doesn't mean that they are hallucinating. Patulous is a real diagnosis, and it does have treatment options. And so I think it's important to give patients hope as it relates to that. So if you have questions, drop them in the comments below, and hopefully this has been helpful and informative for you. Thanks.